Part 3 of the Ethical and Religious Directives provides insight into the professional-patient relationship and our role as Catholic healthcare providers in this relationship. The introduction to Part 3 describes the provider-patient relationship in collaborative terms, with each party having its own responsibilities. And as you read and hear about the directives themselves, note how most of them have to do with specific ways of respecting human dignity within the health professional-patient relationship. There are many directives listed in Part 3, so please review them before watching the introductory video. I'll be back shortly to talk more about the professional-patient relationship as described in this section of the directives.
In the high-pressure environment of emergency medicine, contacts between patient and caregiver may be quick and one-time only. Throughout the Catholic health ministry, patients and providers enter into relationships marked by respect, trust, honesty, and confidentiality.
If you take a look at the recent history of medical ethics in the United States, we went from a time when everything was the physician and people talked about medical paternalism to a point now where everything is the patient and autonomy is really being stressed. I think what the ethical and religious directives do is provide a counterpoint to both of those, rather than simply the physician being in charge or the patient being in charge. What the ERDs want is that this be a team, that the physician has expertise that nobody else has, and that's important. But the patient also has values, and the physician needs to respect those values. So as physician and patient become more interdependent, they work as a team, and that's going to help not only the patient, but the physician as well.
You can't get better if you don't trust your physician or your nurse or your health aide. Those of us in healthcare have a special duty to develop trust and not to betray it with our patients.
When a person crosses the threshold of sickness into the healing hands of caregivers, a special bond is formed. Part 3 of the Ethical and Religious Directives describes the covenant that is created in the professional-patient relationship.
One of the things I have tried to develop with my patients is they're going to trust me. They have to, in a sense, know me. So we do develop a relationship.
A patient will often find himself or herself relating to a number of healthcare providers. The directives articulate principles of dignity, informed consent, confidentiality, and truth-telling to help shape the professional-patient relationship.
Informed consent, whether it's within our tradition or not, requires certain information to be given to the patient so that they can understand, evaluate, and communicate that healthcare decision. It requires things like risk, benefit, prognosis, diagnosis, alternatives to treatment, alternatives to no treatment. But those many traditions have arrived at that same conclusion. It's the impetus within our ministry that calls us to fulfill that expectation of informed consent every single time, so that in that patient encounter, we're not doing it because it's required of us as a reasonable patient standard within the legal tradition. That's important, no doubt. But the reason and impetus behind it is because for a person's dignity to be recognized, it means that the patient has the information necessary for them to carry out a healthcare decision that's going to impact them as a human person.
What the church has said is, we value life so much that we must do all that we can ordinarily to preserve life. But we are never expected to do what is extraordinary or what might be burdensome to the individual or to his or her family in order to preserve life. Ordinary means to preserve life are sometimes defined as medicines, treatments, operations, or procedures that offer a reasonable hope of benefit to the patient, or which can be used or obtained without excessive expense, pain, or other inconvenience. So we look at two things. We look and say, will this benefit the patient? Is this for the patient's good? And on the other hand, will this be a burden for the patient or the patient's family that may in fact outweigh the benefits? But one of the difficulties is that it is something that is quite subjective. How do you determine if this is a benefit to a patient? And it's the patient himself or herself ordinarily who determines if this is in fact a benefit to him or her. And so what it requires is that in the difficult cases, particularly at the end of life, many times there needs to be a wide-based dialogue or communication in order to be able to come to some kind of clarity about what is ordinary or extraordinary for this particular patient.
Medical treatment decisions can be very difficult for patients, families, and providers. The directives help clarify a patient's and provider's responsibility to pursue treatment.
What an advance directive does is it gives the power to the patient to ask for what they need if they get in a situation where they can't ask for what they need or what they want, what they would like to have done. It gives them a voice in case they get to a place where they don't have a voice. And that puts the professional, the healthcare professional, in a position where we know what they want, where the family knows what they want, and where their wishes are carried out. So it's really very, very important. And I think one of the beautiful things about that is it takes the weight or the guilt off of family members when they know that it's what the patient has asked for.
Addressing the tragic circumstance of sexual assault, the directives provide guidance for appropriate, compassionate treatment of victims.
One of the things that you need to do when you're taking care of a victim of sexual assault, you have to do the history, you have to do the physical exam, you have to sew up the lacerations, but you also have to, as part of that healing, you have to restore dignity. And it's just as much a part of the therapeutic process as prescribing an antibiotic to prevent sexually transmitted disease. And Ethical and Religious Directive 36 gives me the freedom to act on an important part of restoring that dignity, and that is the prevention of possible pregnancy as a result of this act of violence. And without that directive, I wouldn't be able to complete that piece of the healing process.
Part 3 of the directives also emphasizes the important role of ethics committees in assisting patients, families, and providers in making difficult healthcare decisions.
As our own ethics committee continues to function in a way that I believe is faithful to the ministry and what we're called to do as an ethics committee for my own health system, I recognize that despite my own training, I'm not a proficient in law. I'm not proficient in being a medical doctor. I'm not proficient in being a nurse. Those are not the gifts that I've been given. And as we approach ethics consultation, ethics education, it means that we do this in accord with a way that's going to serve persons where they're at.
Part 3 of the directives offers a vision of care that promotes healing and hope.
The main aspect of physician-patient relationship is respect, dignity, besides compassionate care, and then, attention to their social and spiritual needs. But compassion and dignity and openness with the patient and the family, explaining them their illness and explaining them the outcome.
These guidelines remind me of why I became a physician in the first place. There's a difference between being a doctor and being a healer. Many people can be healers without being doctors. and many people can be doctors without being healers. I think of this set of work as one of the pieces that allows me to be a healer, in addition to being a physician.
What are some of the takeaways in Part 3? From the introduction, I think it's important to keep in mind the characteristics of a good provider-patient relationship: mutual respect, trust, honesty, and appropriate confidentiality. As I mentioned earlier, the relationship is a collaborative one. Both provider and patient participate in the healing process, and each has responsibilities. Neither the healthcare professional nor the patient acts independently of the other. Both parties participate in the healing process. Above all, the dignity of the person must be respected by all in all circumstances. Neither the nature of the individual's health problem nor social status should make any difference. And when it comes to the directives themselves, respecting a person's free and informed consent, respecting a patient's advance directives and right to appoint a surrogate, taking into account the well-being of the whole person in deciding about any therapeutic measure, privacy and confidentiality, respecting a patient's judgment about ordinary and extraordinary means. These are all expressions of respect for human dignity. One of the directives in Part 3, number 36, deals with the care of victims of sexual assault. This directive calls for compassionate and understanding care, cooperation with law enforcement officials, offering psychological and spiritual support to the victim, as well as accurate medical information, and, if the woman wishes, treatment with medication to prevent ovulation, sperm capacitation, or fertilization. However, it is not permitted to provide treatments that have as their purpose or direct effect the removal, destruction, or interference with the implantation of a fertilized egg.